Welcome to a podcast brought to you by the American Academy of Orthopaedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm excited to bring to you what I think will be an interesting look at some of the financial aspects of delivering manual therapy. This time, our guest is Dr. Stina Lilje. Dr. Lilje started her career working with professional ballet dancers at the Royal Swedish Ballet School in Stockholm, Sweden, in cooperation with an orthopedic surgeon and a physiotherapist. After 6 years, she moved south in Sweden and started her own clinic. She has conducted research on the use of manual therapy and earned a PhD in applied health technology. In her postdoctoral phase, she began working at Karolinska Institute and Lund University. She has also recently finished a prospective cohort study on screening for pregnancy-related pelvic girdle pain. We invited her to the podcast today because she was the primary author of a paper that was recently published in Therapeutic Advances in Musculoskeletal Disease. This paper was titled Cost-Effectiveness of Specialized Manual Therapy versus Orthopedic Care for Musculoskeletal Disorders, Long-Term Follow-Up and Health Economic Model. As always, we'll link to the paper in the show notes. And, without any further delay, let's get to the interview. Dr. Lilje, welcome to the podcast. How are you today?
Thank you. I'm fine. I'm happy to be here at last.
And we, of course, are very happy to have you join us today. And for the record, as soon as I saw the title of your article, I knew that I was going to be interested in reading it. And then upon diving in and exploring the details of the paper, it really piqued my interest even more. I think it's truly interesting work. And I want to thank both you and your co-authors for your efforts in putting this project together.
Thank you very much. I liked when you were in contact because my research on this paper deals a lot with the different professions, and physiotherapists were much involved, though not those specialized physiotherapists. It was more like general physiotherapists that participated in and treated in the study. So that's very interesting. So I was happy when you emailed me.
That's great to hear. I truly love it when we have interprofessional collaboration. It's probably something that we should be doing more. And speaking of which, before we dive into talking about the content of the paper, can you start off by describing your profession for our AOMPT audience? This paper specifically talks about naturopathy, which here in North America could be easily confused with naturopathy, but these are very different professions. And as a result, that's why I'd like to have you clarify for us, what is naturopathy?
Yeah, I see. Naturopathy, it originates from chiropractic, and it was born in the beginning of the century, of the 20th century, I think, translation. And they only treat musculoskeletal disorders, no internal problems or general health problems like some chiropractors do. And naturopathic treatment is focused on the back, but also extremity joints and more on soft tissues than chiropractic. We try to have a holistic view of patients' problems. We try to find the original reasons for their problem. Like you have to think backwards often to find a twisted ankle, for example, if it's the right foot, then maybe you get pain in the left hip because you're compensating. So it's a lot of backwards thinking. And we have quite long treatment sessions. The first session is about 45 minutes. The patient is always involved. We use a lot of patient empowerment. So a few effective home exercises are always involved in the treatment concept. All treatments are done with massage, stretching, and trigger point treatments. And then additionally, when needed, you do high or low velocity manipulation and mobilizations, ultrasonic treatment, or electrotherapy. when needed. And sometimes I find, from my point of view, that you do as little manipulation as needed. Like with surgeons, you cut only when it's needed, sort of, because people might get, what do you see, they might get used to it, and it's better to make them find their own way by small adjustments. My background was with classical ballet dancers, and now it is with pregnant women. So there you need to do it sometimes as little as possible, but you need to do the right thing, sort of. That's what naprapathy is. So very much hands-on and patient empowerment, I'd say. They need to be responsible also for a good treatment outcome.
Excellent. Thank you for that explanation. I think it'll be truly helpful. And I think your description lines up very nicely with what a lot of our AOMT community will understand to be, very similar to a physical therapy practice here in North America.
Okay. That's perfect.
Now, that fundamental background point aside, what is the backstory for this project? In other words, what got you interested in taking a deeper dive into this particular topic as it relates to the financial efficacy of different treatments provided?
Yeah, that's an interesting question. It started when I took my exam, when I graduated from the Scandinavian Naprapathic College. And I got employed in the Swedish Royal Ballet School. I was lucky, so there were lots of sports injuries, and growing the students, they were from the dancers from 10 years and upwards. So it was they were growing also, and there were problems like from the foot and upwards in the body. And they do lots of different dances. So there were lots of injuries, and overuse injuries and acute injuries and on pain, a little of everything. And I had this cooperation with an orthopedic surgeon. And after a while, I found that the students, or the dancers, they were very often frustrated when they had an appointment with a orthopedic surgeon, because they had the feeling that he didn't do anything. And I thought, because he was really a nice guy and he did his best, and I thought that, well, what was he supposed to do, an orthopedic surgeon? Because there were not so many surgical cases, and there were not so many injections needed or x-rays. Most of the problems were treated very nicely with manual therapy. So we changed a little the organization. So they started coming to me instead, and I did this gatekeeping. And so there were only when I needed a second opinion or some surgical cases and things, or if I needed a referral for a specific test or radiography, that I sent them to the orthopedist. But even then, and that was when, like, almost 30 years ago, and even then I thought that this must be so. It's not only that they're not improving when they are seeing the orthopedic surgeon, but it must be costly, because if you don't do the right thing from the beginning, then you can do whatever, and it gets more and more costly, and the patient or student or dancer doesn't get better. So there is actually where this idea sort of was born. And then we're moving south in Sweden and starting my own clinic after 6 years with the ballet. I missed this cooperation with an orthopedic surgeon, so we did in our city with the orthopedic clinic in this city, and then we looked at the treatment effects. And when I was when I was doing this registration in the healthcare, in the information system, I was curious what happened in the control group. So I looked at it a little, and then I saw that there were many things happening, and we had tried to find those patients on the waiting list that were not considered as surgical cases. So they were those low priority patients that they actually don't want to be on the waiting lists, but for whom there is nothing else, because the care is physiotherapy and primary care. And if you're not cured in Sweden with exercises, then next step is an orthopedic surgeon. But yeah, so there is a gap in knowledge. But when I saw how much was happening in the control group, I thought that this must be costly. So there was the idea to continue this research by doing a health economic study. And it showed to be after 12 months, it was dominant, and it means that it's better and cheaper with naprapathy in this case than with standard orthopedic care. And when you do cost effectiveness studies, it's the common scenario is that medication, for example, is better, but it's more expensive. So how much more expensive can it be? That is the question. And our result, when it showed that specialized manual therapy was both better and cheaper. Then it's called dominant, the result. And that's very unusual. So it was great fun. It was a very nice and maybe not so surprising result, but it was an important result.
That is a great backstory. Thank you for sharing it. And interestingly, I think it parallels very nicely with a lot of what I've seen here in North America. And even though we live in different parts of the world and we're involved in two different professions, it's just so interesting to me that we have very similar prior experiences. So again, I think that's part of one of the reasons why it's interesting to have you on the podcast to talk about your findings, even though we do come from such different backgrounds. That point aside, let's move further into the study. Can you tell us about the design of the study? How many participants were there? Where were they seeking care? And what types of treatments did they receive?
There were 78 participants, and they were all referred to an orthopedic county hospital's outpatient clinic, most of them from primary care and some of them from other departments in the hospital. And they were, the most common disorder was shoulder pain and knee lower extremities, which is the same as on the orthopedic waiting list. And the treatment was, the orthopedists, they worked as usual. They didn't know which patient was participating in the study or not. They did that. They worked the way they always do, sort of, with injections and medication, radiography, and some cases were surgical cases, even though we wanted to not include those. And those in the experimental group, they received like specialist manual therapy, like massage and stretching, trigger point treatment, manipulation or mobilizations if needed. So it was a pragmatic treatment concept. Electrotherapy if needed, and home exercises. And they received a maximum of, I think it was like 6 treatments, but in the end, they had an average of 4.1 treatment per patient. And what was interesting was that the majority, or almost half of all the participants, both in the experimental and in the control group, they had been well taken care of before. They had their pain for an average of 6 months. They had injections, radiography, a lot of physiotherapy, general physiotherapy, and all of them had met a physician, since somebody had to make this referral for the orthopedic clinic. So they had been well taken care of before being included in the trial.
Thank you for that description. It helps paint a picture of what we're seeing here in terms of the clinical interactions. And taking that just a little bit further, any clinical study requires a method, and quite frankly, various methods, to measure progress and change over time. How did you choose in this study to measure the health outcomes of these particular patients?
Yeah, that's a good question. It feels a long time ago, but we started with the questionnaire that validated ASF short form 36. And luckily, when I wanted to perform this health economic study, it showed that you can transform the SF36 to encode it to something that is called SF6D. So instead of 8 dimensions, it has 6 dimensions, and you get a point estimate for each question and each patient through an algorithm. And I did this in cooperation with a professor in the Swedish, let's see, what is it called? Health Economic Health Economic Institute at Lund University. So they helped me to encode this into SF60, and it's because then you can calculate QALYs, quality adjusted life years. And when you calculate the QALY, it's like you merge those point estimates, how well you feel, those different domains that are both physical and psychological and social and emotional with the length of time that you are in those different states. So you get an area under the curve. And it's very interesting actually how it's dimensional. So it's a specific way to look at people's health states. So that is what we used. And we also used a visual analog scale to measure the pain when it was three different scales actually, when the pain was at its worst and the average pain for the last, I think, like 1 or 2 weeks. And we measured medication and what did we more measure? All the interventions that were made, and also because some of the patients, they had maybe they chose, like in the control group, they had a chiropractor since before, or some went to a personal trainer or acupuncture or different things. So all those interventions were measured in both groups. And let's see, what did we more do? Yeah, that is what we did. And then we measured the costs that are measured by using diagnosis related groups, DR. There is a price for all interventions in care from let's say painkillers for headache until the worst surgical interventions and staying in the hospital and how much it costs. So we counted on that also. And then you put it together. So it's treatment outcomes plus costs that you put together in the results.
That sounds like a wonderful collection of different outcomes. And over what period of time did you look at these outcomes? In other words, how long was your follow-up? And when you looked at the outcomes, what did your results show?
That's a good question. We started measuring after 3 months, and that was an extra important point in time because until 3 months, the groups were clean, and that means the ones who saw the orthopedists had only orthopedic intervention, and they didn't do any crossover during that time. And the patients or the participants in the experimental group, for ethical reasons, they were allowed to see an orthopedic surgeon in case the manual treatment wouldn't be successful. But this crossover was not done until after 3 months. And actually we were lucky there because it wasn't planned from the beginning, but we saw the pattern and then we thought that, okay, if the groups are clean after 3 months, only orthopedics or naprapathy, then it's easier to measure from that point of time. And then whatever happened until 6 months, and then we measured again, and 12 months. And then it was after 8 years. And there was actually who is responsible in Swedish Orthopaedic Association professor, and she told me that do a long-term follow-up. She said, and long-term, I don't mean it's more 1 year is not a long-term follow-up. It has to be more than 7 years or up to 7 years. And we did it after 8 years, so we thought that when we've done it by the book. So, and what we found was still after 12 months, it was even more expensive in the control group, and the results. Participants in the experimental group, they had better. Most obvious was that their physical function was much more improved than in the control group, and their pain had also decreased more than in the control group. And this was steady. It was even that their physical function kept improving after 12 months. So it was very interesting.
What great results. And an 8-year follow-up is excellent. I really wish we had more evidence within the manual therapy community that had such a long follow-up. You know, I think a lot of us see this in our patient populations. We experience it every day. When you have a really robust approach with your musculoskeletal patients, when you're addressing biopsychosocial variables, when you're getting your hands on their tissue restrictions, we just have the ability, I think, to have a more robust response. But the evidence, as I've seen it, isn't matching up with what I see in clinical practice. So it's one of those reasons why when I saw this study, I thought it was phenomenal. As another follow-up, based on your knowledge of this topic and all the work that you've done into this particular study, how do you think this kind of evidence can help inform clinicians with respect to how they interact not only with their patients, but also with the larger healthcare systems?
Yeah, that's a very good question because that is actually what it's all about. And I think that it is, I reflected on that many times and not least throughout the study. I think that the most important thing is to know where the limits are for each profession's competence. Where does it start and where does it end? And where do I need, or where do the patient need help from anybody else than me as a manuotherapist? And that needs to be clear also in the healthcare system. And I don't find that it is. They keep doing what they have always done. And in Sweden, for example, it's like physiotherapists are employed in hospitals and primary care units, whereas naprapaths are not. And naprapaths were licensed by the Swedish National Board of Healthcare, I think it's called, translated, in 1994. But there are still no naprapaths employed in hospitals. And there are two major things. One is that naprapaths, they could improve, and from the other side, like physicians and orthopedists and physiotherapists could improve also their knowledge about what is the most effective treatment for this patient. If I cannot help him or her, who could? And that there is a learning, there is a satisfaction with that, and possible development in your treatment skills and expertise. And it's also, of course, the question about the patient's well-being and economical. It's an economic issue because many of my patients, for example, in my clinic, they are not like, they don't have a high salary. They are not so maybe well educated. They work in the care. They take care of elderly or disabled people or persons, and they work with healthcare, but they are not well paid. So it's they need the treatment, but they often enough they can't really afford it, or maybe they can afford one or two, maybe three treatments, but then it's enough. So there is some injustice in this also. And I've also worked with quality assurance, and what I like so much about that is that the basic truth in quality assurance is doing the right thing from the beginning and continuous improvement. And if you do the right thing from the beginning, then it doesn't get expensive. So it goes sort of hand in hand. So I think more knowledge about each and everybody's skills and expertise, and more maybe seeing the patient as the customer that he or she is. In Sweden, they are paying treatments through their taxes, and then they have to pay the specialized manuotherapist privately often. So I think that's but where you have to put the focus, as I see it.
Thank you for that answer. I think it's always important to keep the bigger picture in mind. Speaking of which, as my last question, and it's potentially a massive question that we could write a book about, but we'll keep it reasonably simple here. If you could change anything about our healthcare systems, and of course your knowledge is most likely specific to Sweden, or if you have a more general answer as well, that's fantastic. What would you modify to improve the patient experience and, most importantly, of course, health outcomes?
Yeah, how do you do that? I think you would need it already in the education for becoming a physician or a physiotherapist, that they need to know what skills and expertise those specialized manuotherapists have. And not that it's better or worse, but it's just different. And sometimes exercises are needed, sometimes it is knife, and sometimes it's manuotherapy. You need to know about all these things. And I think also that you need to have a price for for almost everything. Everything costs, and everything, like money, it affects everybody's everyday life. So you need to look at it from that point of view also. How much does it cost? How effective is it? And also the research community, more cost effectiveness studies. There are a few in the Netherlands, for example. They don't, when you apply for research for funding, you don't receive any grants if you, for an RCT, for example, if you don't perform cost effectiveness study alongside. And I think that's very wise, though there is, as you know, have noticed and mentioned also, that follow-ups for more than 12 months, they are very, I don't think they exist really before this one, and this is a small one. Though we did a power calculation, so it's big enough, but we need more. So that's for the research community also. So educational and for the research community, and economically. Yeah, as easy as that.
Yeah, I love the point about it being as easy as that. As I mentioned, it's a practically impossible question, but you did an excellent job with that practically impossible question. Thank you for taking it on. If I were to sum it up, and I'm sure you agree, it would be perfect and ideal if we had the right professional education and the right patient care for the right people at the right time. But that is such a massive, overarching topic globally that it's, of course, easier said than done. We could talk about entry-level education being effective and efficient, the same for post-professional education. And if we do those things right, then hopefully our patient care would be good enough to help us be as effective and efficient as possible when working with patients. But then it gets so complicated between reimbursement and laws and politics. And it's just, of course, the type of situation where we've spent decades or centuries creating the health systems that we all live within, and it could take decades or longer to study them, attempt to reform them, study them more, make additional adjustments to improve the things we didn't improve before. I would imagine a huge cycle of ongoing frustrations that hopefully would end up somewhere close to an ideal system, but I'm not sure such a thing can exist. But until then, it has been a truly wonderful and informative conversation. I want to thank you for bringing your expertise to the podcast and to our audience. I secretly hope that you have more studies like this in the works because I look forward to reading them in the future.
Thank you, Stephen. I was really happy, though nervous about this interview. But I was very happy that you emailed me and were truly interested in the study, and not from a critically negative point of view, but from let us create something together. And yes, I'm really happy to be here. And actually, I've just finished a study on screening for pregnancy-related pelvic girdle pain, and so hopefully I can get back in the future and tell you about the results because they are very interesting.
That sounds wonderful, and perhaps we can plan for a post-publication visit and then an 8-year follow-up visit.
Yeah, that's good. That's a good perspective.
And once again, thank you for joining us, and we'll see you sometime in the future.
Yeah, thank you.
This has been a production of the American Academy of Orthopaedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.